Hello and welcome or welcome back, depending on the number of times that you have visited my channel or looked at my videos, watched something, or maybe this is your first time. In that case, welcome, and if not, then welcome back. So today, in this discussion of ours, as you can already see, this is an anatomy discussion. Today's scope of discussion will be about the side of the neck. Okay, so we are studying in the head neck region, we're studying about the neck. And in our last discussion about the neck, we had studied about the superficial structures related to the neck. So we had studied the skin, the platysma, which is a subcutaneous muscle. We had also essentially studied about the external jugular vein, its different tributaries, and the different clinical correlates as well. Now we are going into the more deeper structures, and uh, in that, the first aspect that we talk about in the neck is the side of the neck. Okay, so that's what the scope of this discussion will be. So the very first thing which obviously everybody can appreciate is the neck region. So we can all see as to what the neck region is. Okay. However, there is a proper anatomical demarcation as to from what to what is called the neck. Okay. So there is a proper anatomical boundary of the neck, and that is the first thing that we are going to define here. So this neck, or rather the sides of the neck, right here, the sides of the neck, because our scope of discussion today is about the sides of the neck. They are, as you can all see, quadrangular, right? See, they're quadrangular. I know it's a little bit, jumbled up because of the number of so many muscles are present. That's why it might be a little bit hard to follow on, but still you can all make out that this is a quadrangular structure on either side. Okay. Now, let's talk about the anatomical demarcations of the side of the neck. So from what part to what part will we call that this is the side of the neck that we're talking about? So now listen to me very carefully. See, in the anterior region, let's first mark out two muscles, okay? Two very important muscles. See, the mouse pointer right now, it's resting on one muscle, this muscle. I hope you can all see this. Yes, this is the key muscle of the neck. And this muscle is, yes, Sternocleidomastoid. Okay, so this is the Sternocleidomastoid. And as it's given here, it's the sternal head, because the Sternocleidomastoid has two heads, sternal head, and this is the clavicular head. Anyways, we'll talk about it in just a moment. So this is the sternocleidomastoid, and this muscle, this huge muscle, which is so expanded posteriorly, this muscle is the trapezius muscle. Okay, so this is the trapezius muscle. So these are the two very important muscles which you must know. Okay, for boundary demarcation of the neck. Now listen to me very carefully. As far as the anterior border of the side of the neck is concerned, if you remember, I had said that the neck has two triangles, right? It's divided into two triangles. The first is the anterior triangle. And the second is the posterior triangle. We'll talk about those in a while. But why I actually brought that up is, if you remember, when I had talked about just a little bit about the anterior triangle, I had said that the anterior triangle is bound anteriorly by the midline, or the anterior midline of the neck. So this over here, it's not actually a line, it's an imaginary line. So an imaginary midline anteriorly present, which is dividing the entire neck into two halves or two parts, the left half and the right half. So this imaginary midline is the anterior boundary or anterior demarcation of the side of the neck. I hope I am understood here. Okay. So that's the anterior extent. What about the posterior extent? See, I just now said that this is the what muscle? Yes, the trapezius muscle. So the anterior border, look at the mouse pointer. The anterior border of the trapezius muscle serves as the posterior demarcation of the side of the neck. Am I understood? See, this is the trapezius muscle, and this over here, as the mouse pointer is moving, is the anterior border of the trapezius muscle. So this border, anterior border of trapezius, is actually what? Yes, it's actually the posterior demarcation or posterior boundary of the side of the neck. So the side of the neck is up to this, whereas this is the posterior part of the neck. Okay, so this over here is the posterior part of the neck. The side of the neck is only extending up to the anterior border of trapezius. Okay, and what about the anterior border of the neck? That is the imaginary midline. Okay, but we need, since it's quadrangular or quadrilateral, anyways, so it must have two other boundaries as well. The superior boundary, it's very self-explanatory, excuse me. The superior boundary is, yes, the base of the mandible, right? The lower border or the base of the mandible, right? But there is an additional thing that you have to talk about here. That additional thing is, see, this is the masseter muscle that we all know from our prior discussion on mandible. So this over here is the base of the mandible, right? But the base of the mandible ends with the angle of the mandible over here. We can all make this out, right? I'm not, isolating the masseter muscle because we all know this. So base of the mandible extends only up to here, but neck does not only extend up to here, neck also extends up to this much. So what about this much whole part? For that, we say that an imaginary line joining the angle of the mandible to the mastoid process of temporal bone over here. This is the temporal bone, this is the mastoid process. So an imaginary line joining the angle of mandible to the mastoid process of temporal bone also acts as the superior boundary of the side of the neck. And also along with that, we have the base of the mandible. So the superior boundary, I am repeating it again, the superior boundary is the base of the mandible, the lower border of the mandible, and along with that, the imaginary line joining the angle of the mandible with the mastoid process of temporal bone. Done. What about the inferior border? Very easy. There is only one inferior border and very simple. That is the superior surface, or rather not the surface, superior border of the clavicle. The superior border of the clavicle acts as the inferior border of the sides of the neck. Okay, so this is roughly the demarcations of the sides of the neck. Now let's talk about the two subdivisions of each side of the neck. We have already mentioned this, but I'm still repeating it, obviously. Each side of the neck, the side of the neck is roughly a quadrangular area. So each side of the neck is divided into two triangles, two triangular areas. Okay. One is known as the anterior triangle. What is the location of the anterior triangle, if I may? So the anterior triangle, as far as its boundaries are concerned, as I've already mentioned, it's bounded anteriorly by the imaginary midline, right? The imaginary midline which is running along vertically. It is bounded, its base rather is the lower border of the body of the mandible over here along this, and its posterior border is none other than the anterior border of sternocleidomastoid along this. Okay, so if we are to join these three together, see, we are getting a triangle or a triangular area, and this triangular area is the anterior triangle of the neck. Whereas if you can see here, it's very self like clear from the model itself. This is another triangular space. See, that this triangular space is bounded anteriorly by, what is this muscle? This is the sternocleidomastoid only. So this is bound, this space, this triangular space, this is bound anteriorly by the posterior border of sternocleidomastoid right here. Okay, whereas this space is bound posteriorly by the anterior boundary of trapezius over here. Okay, and the base of this triangular space is formed by the superior border of the middle third of the clavicle. So this space is known as the posterior triangle of the neck. Okay, so our discussion today will be primarily concerned on the posterior triangle of the neck and not the anterior triangle. We will talk about the anterior triangle in subsequent discussions, but today's discussion will be mostly about posterior triangle. However, before moving on to the posterior triangle and talking about it and its contents, let's very quickly learn a few things about this very important muscle, which is sternocleidomastoid, because it's very important. And as I have already mentioned in this video only initially, that this sternocleidomastoid muscle is the key muscle of the neck. It's the key muscle of the neck, and very rightly so, because as you can see that sternocleidomastoid is the demarcation, or it is the muscle which is demarcating the you can say anterior triangle and posterior triangle. So it's separating these two triangles, right? Right. So let's talk about the sternocleidomastoid. As I've already shown you from the model itself, and you can pretty much see for yourself, sternocleidomastoid has two parts, or rather two heads. Okay, see, this head is originating from the sternum. This over here is the sternum, or rather the manubrium sterni, and this is the sternal head of sternocleidomastoid. So where is the sternocleidomastoid's sternal head taking origin from? Well, it's taking origin from obviously the manubrium sterni, but if we are to be a little more precise, then it's taking origin from the superolateral part, supero, because this is the superior part, right? And a little lateral, not midline, a little lateral, superolateral part, obviously of the front of the manubrium sterni, and below what? Below this notch. This notch is the suprasternal notch. So manubrium, or rather, I'm sorry, sternal head of sternocleidomastoid takes origin by a tendon. By the way, this is a tendon, so this is a tendinous origin, very much self-explanatory. A tendinous origin from the superolateral surface of the manubrium sterni, a little below the suprasternal notch. Okay, and then after taking origin, this head, it's passing obviously, yeah, this is more appreciated from the anterior view. This is passing, as we can see, upwards, a little backwards, and obviously without question laterally. Okay, so it's passing upwards, no doubt about that. A little backwards, which is appreciated from the lateral view. See, it's passing backwards, right? Right, so it's passing backwards, so it's passing upwards, obviously, backwards, obviously, and laterally, most obviously. Okay, okay, so that's that about the sternal head. Whereas we have another head, which is the clavicular head of the sternocleidomastoid. So this clavicular head, um, the clavicular head, as you can all see, it's taking origin from the clavicle. That's why it's known as a clavicular head. So this actually takes origin from, if you remember clavicle's anatomical domain, you will remember that it actually took origin from sternocleidomastoid. The clavicular head took origin from the middle 1/3 of the superior surface of the clavicle. Okay, so this is actually a little misleading. It's almost as if it's taking origin from the uh, medial 1/3, but it's not actually medial. It was, we all know that it's superior surface of the clavicle, right? So it's more so about the middle 1/3 of the clavicle, superior surface of the clavicle, obviously, deep to this head, and this is pretty much well appreciated. See this head, this is the sternal head, right? The sternal head is more, it is more anterior, it is more superficial, whereas the clavicular head is a little deeper, right? It's a little deeply placed, a little deeply placed. These details are not that well needed in first year anatomical classes, but I think that these are extremely needed in surgery. As I was seeing a lot of surgery videos, and I saw that whenever the teacher explains, he or she is very much detailed about whether a tendon is, you know, a little more superficial, a little more deep. So all these microscopic things affect macroscopically in surgery. That's why I think it's worth remembering. And it's pretty easy and self-explanatory as well, that the clavicular head is a little deeply placed than the sternal head. And as you can see, the sternal head was much more laterally running, whereas the clavicular head is much more vertically running. And it meets the sternal head, and together they move up over here. Okay, so that's that about the origin of sternocleidomastoid. Now, just a small thing, very quickly. You can all see that there is a triangular space in between the sternal head and the clavicular head. This triangular space I'm talking about. This triangular space, as you can all pretty much appreciate, is superior to the clavicle, right? It's superior to the clavicle, so it's supraclavicular. So this fossa or this space is known as the supraclavicular fossa. But there is a but to this. But there is another supraclavicular fossa, which is essentially this triangular space over here. See, this triangular space, right? This triangular space is also above the clavicle, so it's also a fossa. Rather, it's obviously a fossa, and it's also above the clavicle, so it's also a supraclavicular fossa. So since this is the bigger of these two, so the smaller one is known as the lesser supraclavicular fossa, and the greater one is known as the greater supraclavicular fossa. This greater supraclavicular fossa, as we will later see, is actually also known as the subclavian triangle. Okay, we'll see to that later. So that's that. Okay, now we talked about the insert, or rather the origins, right? Okay, another thing, I almost forgot it, excuse me. Very important clinical correlation of this lesser supraclavicular fossa lies in the fact that this space essentially lodges an important vein. What important vein? The internal jugular vein. Yes, or rather, to be more precise, terminal part of the internal jugular vein. So the terminal part of the internal jugular vein, please do me a favor and remember this. terminal part of internal jugular vein is lodged in this small triangular fossa, which is the lesser supraclavicular fossa. Okay. Okay. Having talked of that, having talked of the origins, let's talk about the insertion. So very much self-explanatory that let's first talk about which bone or bones the sternocleidomastoid is attached or rather inserted to. This over here is no doubt the temporal bone, right? And this over here is no doubt the posterior most bone, so this has to be the occipital bone. So, and we can see the suture in between them. That's why I could say that these are separate bones and not the same bone. So this over here is the temporal bone, and this is the occipital bone, and we can see that it's actually extending to both the bones, right? The insertion. Now, let's talk about the insertion a little more detailed way. So insertion of sternocleidomastoid, just like it had two origins, in just that fashion, it has, I wouldn't say two insertions, but it has two places of insertion. One is at the temporal bone and the other is at the occipital bone. So at the temporal bone, we say that the sternocleidomastoid gets inserted by a thick tendon. As we can see, this is a very thick tendon, although it looks a bit flattened as well in this model. So I wouldn't bet on that. Anyways, so the sternocleidomastoid gets inserted by a thick tendon to the lateral surface of, what did I say over here? What was the imaginary line joining these two things? Yes, this was the angle of the mandible and this was the mastoid process. So this here is the mastoid process of the temporal bone. So sternocleidomastoid gets inserted by a very thick tendon. Not, you can you can omit the very over there, got a little carried there. Anyway, so it gets inserted by a thick tendon to the mastoid, or rather the lateral surface of the mastoid temporal bone. Okay, whereas this was a thick tendinous insertion, whereas a little flattened insertion or an aponeurotic insertion is seen at the occipital bone. Where in the occipital bone does it get inserted, to be more precise? Yes, the lateral surface of the superior nuchal line. Okay, now listen to me very carefully. For this, prior anatomical knowledge of occipital bone and temporal bone is needed. Okay, for the temporal bone, it's a little fairly easier to understand the insertion, because you just have to know that there is a process known as the mastoid process over here, over which sternocleidomastoid is getting inserted. But for the occipital bone, it's a little more detailed. So anyways, I've already made a video on occipital bone. I'm yet to edit it, so occipital bone video will be coming out very shortly. In the meantime, you can just know that occipital bone has a set of lines on its posterior surface. Okay, they are known as the nuchal lines. Okay, they are very important landmarks. So of the nuchal lines, there is a highest nuchal line, there is a superior nuchal line, there is an inferior nuchal line. Among those three, in the superior nuchal line, sternocleidomastoid gets attached. Where in the superior nuchal line? And trust me, this much detailing is worth it, because a lot of muscles get attached to the occipital bone along the nuchal line. So you have to be this much precise. Okay. So where in the superior nuchal line? In the lateral end of the superior nuchal line. Very amazingly enough, trapezius also gets inserted along the superior nuchal line, but a little medial to the this thing, sternocleidomastoid. Okay, but we'll see to trapezius later, not now. Now we are talking about sternocleidomastoid. So there are two insertions over here. One is along the mastoid temporal bone, lateral surface of the mastoid temporal bone, by a thick tendon, and by an aponeurotic insertion to the superior nuchal line's lateral part of the occipital bone. Done? Done. Having talked of the origin, the insertion, now let's talk about the other aspects of sternocleidomastoid, namely the blood supply. Okay, very simple, very simple, very simple. See, there is not one artery which supplies the sternocleidomastoid, and that's very obvious. Why? Because sternocleidomastoid is such a long muscle, it's such an extensive muscle. So obviously, since there are a lot of arteries which are going on through here, sternocleidomastoid has multiple sources of blood supply. Okay, so bear with me when I talk about the blood supply of sternocleidomastoid. Sternocleidomastoid receives arterial supply or blood supply from, we can say, to be 4 arteries. Not to panic, not to panic. It's pretty logical. Okay, listen to me. Sternocleidomastoid's upper part. How much upper? I have not read about that. Like from what part to what part you can call to be the upper part of sternocleidomastoid, I don't really know that. But grossly speaking, the upper part of sternocleidomastoid is supplied by, okay, here comes logic. Here comes logic. What bone is this? This is the occipital bone. This is getting inserted along the occipital bone. So what artery can be present in the upper part of the sternocleidomastoid? Yes, the major artery, occipital artery. So occipital artery supplies the upper part of sternocleidomastoid. However, it is not the only artery. There is another artery which supplies the upper part of sternocleidomastoid, and that is, I'm giving you a hint. This over here is the auditory canal. So there is a structure which lies over here. What is that structure? Our ear, our auricle, right? Our auricle. So you can see that this area where my mouse pointed right now is, this one is posterior to the auricular area. This is the auricle. This is where the auricle will lie, right, in the body. And this over here, where the sternocleidomastoid's upper part lies, this is posterior to the auricle. So what will be the name of the artery which is posterior to the auricle? Yes, very common name. Got it. Posterior auricular artery. Very good. Occipital artery and posterior auricular artery are the 2 arteries which supply the upper part of sternocleidomastoid. I think it's pretty logical. Let's talk about the middle third of the sternocleidomastoid. So the middle part of the sternocleidomastoid is supplied by, okay, here is another logic. There is a gland which lies over here. What gland? An endocrine gland, extremely important. We'll talk about that in physiology. Although its anatomy is also important, but physiology is where it really shines. What is the gland which is present over here? Endocrine gland, very important. Yes, thyroid, the thyroid gland. So thyroid is supplied by the superior thyroid, inferior thyroid arteries. These are related to the anatomy of thyroid gland. Anyway, so the middle part of sternocleidomastoid, as you can see, it's pretty much, I can say, at the same level as the thyroid gland. If that wouldn't be an overstatement to make, I think that's the correct thing to say. But at least for remembering purposes, you can obviously remember that the thyroid gland almost lies at the same level at the middle third of the sternocleidomastoid, right? So the middle part of sternocleidomastoid is supplied by, yes, very easy, superior thyroid artery. Superior thyroid artery. Okay, pretty logical. At least, like, we are getting the job done. That's what's needed. Okay, now let's talk about the last part, which is the lower part of sternocleidomastoid. Here is a part where I think it's a little, wacky. It does not really match, although it matches a little bit. The logic matches a bit, but not that much. I would have been happier, as far as the logic is concerned. I would have been happier if the artery supplying the lower part of sternocleidomastoid would have been supraclavicular artery. But unfortunately, that's not the artery which supplies the lower part. The lower part is supplied by suprascapular artery. Okay, suprascapular artery. So that's one thing I would say that you may need to remember a bit. Although I remember it in this way that you know, the lower part of the clavicle, rather the lower part of sternocleidomastoid should have been supplied by supraclavicular, but I remember that it's not. Then what's the other artery that can supply it? Supraclavicular. Yes. How about suprascapular? Yes. So suprascapular artery is the artery which supplies the lower part of sternocleidomastoid. So in total, four arteries. What were they? Posterior auricular. See, I'm pointing at the auricle and posterior. So posterior auricular, occipital. See, so occipital artery, upper part done. Middle third is done by the superior thyroid artery. The lower part is done by supra, not clavicular, suprascapular artery. Done? Done. So that completes the arterial supply of sternocleidomastoid. Having talked of the arterial supply, let's talk about the nerve supply next, right? The immediate thing that should come to your mind when I say nerve supply of sternocleidomastoid is spinal accessory nerve. This is one such nerve you must remember at any cost. It is an extremely high yield information. You must remember this even if you have to spend a few ATPs to remember it, a few extra ATPs to remember it. Do it. It's worth it. Why? You will see when we'll talk about in a detailed way about the posterior triangle. Spinal accessory nerve is very important, and spinal accessory nerve is, as we all know, the 11th cranial nerve. So spinal accessory nerve is the major nerve supplier of sternocleidomastoid, whereas mostly sensory and proprioceptive sensations of sternocleidomastoid are carried by the ventral rami of C2 and C3. Okay, so this is one such area where I could not think of any, logical correlation as such. So this is hardcore memorizing. I cannot help with that. I hate hardcore memorizing parts, but this is one small information that I think it's quite high yield and it's worth remembering. So do me a favor and remember this. Okay, spinal accessory nerve C11, or rather the 11th cranial nerve, and not C11. C11 means you get me, right? That's cervical. That's not what I meant. The 11th cranial nerve, and that is one nerve supplier, and the sensory nerve supply, or the proprioceptive sensations, those are carried by the ventral rami of C2 and C3. Okay, C2 and C3. Having talked of the arterial supply and the nerve supply, the supply of the sternocleidomastoid, let's now talk about what the sternocleidomastoid actually does. This is where it gets completely logical. You would have panicked if I said illogical, right? No, it gets very logical. And trust me, not all muscles can be explained logically, their actions rather. I have tried very much to, logically correlate actions with muscles and their origin insertion. But in many cases, I have seen that they do not work out that well, because our anatomical knowledge is not that detailed to know about it. But thankfully, sternocleidomastoid is one such muscle where it's very obvious what it will do and how it does so. So bear with me when I talk about the actions of sternocleidomastoid. See, let me remove the platysma. Okay, so this is the platysma muscle, by the way, and I had removed the platysma muscle from here, from this side. So sternocleidomastoid is originally covered by the platysma muscle, and obviously by the skin and other subcutaneous tissue as well. So let's hide that. Now we have a clear vision of both the sternocleidomastoids. Now let's quickly look at what it does. See, very, very simple. Sternocleidomastoid, as I have said, has two heads, the sternal head and the clavicular head. Why I bring this up is because of the fact that these two heads, when act, they produce different actions. What do I mean by that? See, the sternal head, I said that it was lateral, a little oblique, and the clavicular head was a little more vertical, straight. How this is clinically, or rather, how this correlates with the action of sternocleidomastoid is that this is the right side sternocleidomastoid, this is the right-sided sternocleidomastoid, right? So the sternal head of this sternocleidomastoid, if this contracts, what it will do is the head will turn to the other side. The head will turn to the other side. See, it's logical. Try to think of this. Suppose this is a rope, okay? The rope is actually attached to over here. Forget about the clavicular head. Just think that there is a sternal head, okay? The sternal head is this oblique, right? So if the sternal head acts, if the sternal head is pulling, or rather if it's contracting, right? So this is the origin. Origin remains static. It is the insertion point which, is contracted. That's the definition of origin and insertion, right? So if this is, pulled, if this part is pulled, try and think about this, right? If this part is pulled this way, then the head will, what it will do? It will turn to that side. It will turn to that side. Try doing this. If you have a little longer hair, what you can do is you can try pulling the hair which is at the extreme lower end, or dangling from your shoulders. Try pulling that from obliquely, and you will see that the head will turn to the other side. It will rotate to the other side. The head here will move to the other side. So this exactly is what I meant when I said about the action of the sternal head. So this is that's why it's a pretty good application here, 3D application. It even shows you the motion for a select few muscles. So I'm pretty glad that they had given the sternocleidomastoid action. But here there is a problem or anomaly given, that they are showing that this is the clavicular head which is doing the motion. That's actually not correct. I actually went on to check the other motions as well, and they showed that all of them were highlighted to be the clavicular head, which is not correct. So kindly ignore this yellowing, flashing clavicular head. Ignore that. The real thing is, it's pretty logical. Here, you can see that there is a rotation of the head and neck towards the left side, right? Towards the left side. So it's the right-sided sternocleidomastoid, or rather the right-sided sternocleidomastoid sternal head, which is pulling. See, it's pulling. It's pretty obvious. It's pulling. That's why it's moving to that side, right? So it is the right-sided sternal head sternocleidomastoid which is contracting, causing a left-sided rotation of the head. Now, this has a particular anatomical, I would say, literature behind it. This kind of a motion is known as a contralateral rotation. Contralateral means that the side of the left side, or rather the right-sided sternocleidomastoid, is producing a motion towards the left side. So one-sided muscle or one-sided thing is causing motion towards the other side. That is known as contralateral. So as if they are contradicting themselves, right? The right side is causing a motion towards the left side. The right sternocleidomastoid causes a motion towards the, or rather rotation towards the left side. So this is known as a contralateral rotation of the head. So this happens when the sternal head of sternocleidomastoid acts independently. Okay. Now, what happens when the clavicular head, which they have highlighted over here, when that acts independently? What happens then? See, it's pretty logical. if this clavicular head, which is this vertical band, if this vertical band is to, contract, it's very obvious that the head will not rotate, it will tilt to that side. There will be flexion of neck. So this is known as the lateral flexion of the neck. So let me show you. Yes, see this. This is the action which is produced by the clavicular head of sternocleidomastoid, provided it is working alone. Okay, it's working alone. So this is the left-sided flexion, left-sided lateral flexion is occurring. This is the left-sided sternocleidomastoid clavicular head working. So the left sternocleidomastoid's clavicular head causes the left lateral flexion of the neck. So this is not contralateral, this is same-sided. So this is known as ipsilateral. So there is ipsilateral flexion of neck. When the clavicular heads of sternocleidomastoid act alone. We have talked only alone as of now. So when sternal head acts alone, there is a contralateral rotation of the head. When clavicular head works alone, there is an ipsilateral, same-sided, ipsilateral flexion of the neck. Okay, done? Now we will see what happens when both of them act together. When both of them act together, see, they are anteriorly originating, posteriorly inserting. If there is a pull from both of them, from anterior, the posterior part is being pulled anteriorly. So what will happen? The head will, it will be kind of a bending of head. Pretty obvious, the head will bend. So that's like this over here. So the head will, see, there is a bending of the head when both of them will act together. Okay, so this is also when both of them are acting together, they're pulling the neck forwards, they're pulling the posterior part forwards, excuse me, and hence there is a bending of the neck. So as if when we are eating food, we bend our head forwards, or when we get out of a pillow, we bend our head forward. So that's the combined action of both the sternal head and clavicular head. So the sternoclavicular, or the sternocleidomastoid has two actions, or rather three, and I have already mentioned all those three. Another, you may say, accessory function of sternocleidomastoid is that in case of forced inspiration, it acts as an accessory muscle of respiration. Okay, in case of forced inspiration, it will act as the accessory muscle of respiration. Okay, done. So having talked of the actions of sternocleidomastoid, the arterial supply, the nerve supply, all of that, now we are left with I think the most extensive part of the discussion of sternocleidomastoid, that being the relations of sternocleidomastoid. Okay, the relations of now let me be perfectly honest here. Relations in anatomy, I think, is the worst thing. Like, I absolutely hate relations in anatomy because many of them are logical, but many of them are like you won't remember them that well. Like, it's logical that it's there, it's around the same place, but this thing is related to that, but that same thing will not be related to a very nearby structure. I've seen this happen a lot of times. So that's one of the main reasons why I really don't like the relations in anatomy, but they are very crucial also, so there is no denying them. But here I want to give you a disclaimer. The disclaimer is, I'll be talking about the superficial relations only, not the deep relations, and I really want to be excused in this one, The reason for that is the in this application of mine, the arterial venous supply, these systems, they're not working that well. The nervous systems not really working that well. So I'm actually having to manage with the muscular system and the skeletal system only. These are not, these sometimes come, it's a hit and miss kind of thing. I don't know what's happening. This application just got updated, so the deeper relations, if I keep saying the names of what is related to sternocleidomastoid and what and how, it will be like mugging it up. So it's better that you maybe open up the anatomy textbook and go through it. The deep relations of sternocleidomastoid, extremely extensive. Like, I could not understand how one is supposed to know all of that. It is very extensive. Like, the superficial relations are very much manageable because we already have a good understanding of the superficial structures of the neck. But the deep relations, very, very nightmarish. So please do me a favor. That's why I'm keeping a disclaimer here itself. And in the description of this video also, I'll put it in blocks and caps and the front line itself, that this will not, I will not be able to talk about the deeper relations of sternocleidomastoid. So I really apologize if that is the sole reason why you came to this video, but I'm really sorry for that. But let's get on with the thing that we can manage, that is superficial relations. Very, very basic. Sternocleidomastoid, it's what are the superficial things to sternocleidomastoid? Obviously, the superficial structures of the neck. What were they? The skin, very common thing. Platysma, very like I just isolated it, so you already know it's going to be platysma. Okay. Nerves, remember this. Now try to remember this. There were 4 cutaneous nerves in the neck, and I had given you a very, I would say, effective mnemonic to remember them. Do you remember that? Lord Gerald's Tech. Lord Galleon's Tech. I'm sorry. Lord Galleon's Tech is super cool. That was the mnemonic for the 4 cutaneous nerves of the neck region. Those 4 cutaneous nerves are actually the superficial relations of the sternocleidomastoid. So what were they? Lord Galleon, L-O, Lord, L-O, lesser occipital. Okay. Galleon, G-A, great auricular. Lord Galleon. Tech, T-C, transverse cervical. Tech is super cool, SC, supra, I would say supraclavicular, not cervical, because we have already said transverse cervical. So again, supracervical, no, and there's not even, I don't think there's a name like that. Supraclavicular. Okay, so these are the 4 cutaneous nerves, which are they are the 4 cutaneous nerves of the neck, and they are also the superficial relations as far as neck, or as far as the sternocleidomastoid is concerned. Okay, so skin is there, platysma is there, the 4 cutaneous nerves are there. We have talked about all of that. Another thing that we had talked about was a vein, which was, yes, very simple, external jugular vein. Very simple, external jugular vein. So the external jugular vein is also related to the sternocleidomastoid. Now I'm not showing you these because, as I've already mentioned, these systems are not working that well for me, so I'll have to take a look at that. But I think I'll fix it by the next video, so please excuse me for this one. But I think these are pretty self-explanatory, and if you want some reference for models, I think you can refer to my previous video on anatomy as far as the neck is concerned, the superficial structures of the neck. Okay, so kindly refer to that video, and you will see that the external jugular vein, it kind of pierced approximately 2.5 centimeters above the clavicle. So we are not going into the details there. Okay, now external jugular vein is thus another relation of the, or the superficial relation of the sternocleidomastoid. And another superficial relation is, if you remember, the parotid gland over here. So this over here is the parotid gland. So parotid gland, it's also another superficial relation of the sternocleidomastoid. Okay, so that's all for the superficial relations of the sternocleidomastoid. I'm very sorry I won't be able to explain or rather discuss about the deep relations of sternocleidomastoid. It's extremely extensive. So I would say that, watch some other video for that. Although I think there isn't any such good video out there which explains it that well. I'm not boasting myself here. I'm not advertising myself. But I haven't found anything pretty much explanatory or that satisfactory. So it's pretty much you have to do it yourself. Anyways, so please excuse me for that. So having talked of the relations or whatever we could about that, let's lastly talk about the clinical correlation of the sternocleidomastoid. And there is only one extremely important clinical correlation of sternocleidomastoid. That is, suppose the sternocleidomastoid and trapezius as well, you may include trapezius as well in that. For some reason, if they are uncontrollably contracting, then what will happen is a condition which is known as torticollis or wry neck. Torticollis or wry neck. In that condition, there is an involuntary head bending to one side. Okay, so the head will essentially bend to one side. There will be a flexion of the head, which I was talking about when I was talking about the action of sternocleidomastoid. So if you remember that, when the clavicular head, do you remember when the clavicular head alone works, there is a lateral ipsilateral flexion of the neck. You remember that? That kind of a flexion will keep occurring, but involuntarily, like the person is not in control of that kind of a contraction. That condition is known as torticollis or wry neck. Okay, so the neck will bend to one side, and the head is bent to one side, and the chin will point to the opposite direction, right? So that's pretty obvious, because if the head bends towards the left side over here, the chin will point towards the right side, right? So torticollis occurs due to a sternocleidomastoid involuntary malfunction. But why or how does it occur? So there can be a number of reasons for that. And based on the reasons, torticollis can either be temporary or can be permanent. Okay. Now the temporary causes, in temporary causes, the torticollis might be spasmodic. That is, there is a recurrent contraction of sternocleidomastoid, and along with that sometimes trapezius as well. Recurrent means that it won't be contracted. It will keep contracting. So suppose the person is normally sitting like this. Okay, suddenly there will be a very painful contraction of let's suppose the right-sided sternocleidomastoid and trapezius. So that will cause an ipsilateral flexion of the head, right? And it's very painful. Again, the person will be able to after a short period of time, maybe he will return back to his normal state, right? Again, there will be a painful involuntary contraction, which will again lead to the person ipsilaterally contracting flexing his head. So this is called recurrent condition. It's keeping on repeating. It's not that the person has his head bent permanently or anything like that. The head, it's not contracted continuously. It's contracting and then relaxing and again contracting. So there is a recurrent contraction, and that's known as spasmodic torticollis. okay, or spasmodic torticollis or wry neck. Wry neck is another name for torticollis, okay. So that's spasmodic torticollis, and it's very painful, as I've already mentioned. And what about the causes of torticollis, or rather spasmodic torticollis? Well, spasmodic torticollis is supposed to be or considered as a temporary form of torticollis. So it's not like um, that will keep occurring permanently throughout his or her life. After some time, which might range from days, maybe, I don't know the actual span of time, but after some time, even without treatment, the person will be again normal, okay. And why that happens is mostly unknown. Mostly torticollis as a whole mostly is unknown cause, so it's known as idiopathic torticollis. Idiopathy means whenever something is not known about the cause of a disease, that's when the disease is known as idiopathic. So torticollis is sometimes, or many times, it's idiopathic. So spasmodic torticollis is also sometimes idiopathic, but other times the cause can be deducted or deduced rather, and the cause may be due to cold. It's a very common occurrence actually. I mean, due to excessive cold, there might be spasmodic torticollis, right? And there is a very painful contraction and ipsilateral flexion of the neck. So cold might be there. Maladjustment while sleeping, the maladjustment of pillow, incorrect posture of the neck or head neck during sleeping, maladjustment of the pillow, that also might cause wound to the sternocleidomastoid, leading to its torticollis, or leading to its irritation, and hence leading to contractions of it involuntarily, right? So these are some of the causes of spasmodic torticollis, and spasmodic torticollis is mostly temporary. Another cause for torticollis might be, if you remember, this sternocleidomastoid was supplied by spinal accessory nerve. So spinal accessory nerve, if that is irritated or something happens to that injury, then that also might lead to torticollis. That kind of torticollis is known as reflex torticollis. Okay, reflex torticollis. Although I was not able to deduce whether reflex torticollis is permanent or temporary. This I was not able to find, but I implore all of you guys to search on the internet whether reflex torticollis is permanent or temporary. I'm yet to know this. Okay, so kindly excuse me for that. But essentially, reflex torticollis is when there is an irritation of spinal accessory nerve. And another very interesting cause for torticollis is known as trochlear torticollis. Now, this is very interesting. So listen to me very carefully. You see, trochlear torticollis is sometimes the person's sternocleidomastoid, spinal accessory nerve, trapezius, all the things, all the muscles and nerve structures associated with the neck, everything is normal for a person. Okay, suppose. But suppose that person has received an injury in the trochlear nerve, which is essentially the fourth cranial nerve. Okay, suppose this has happened. Now, trochlear nerve, what the trochlear nerve supplies is, it supplies the eye muscles, extraorbital muscles or extraocular muscles. Now, we will talk about the eye muscles later, but there is one eye muscle or extraocular muscle which is known as the superior oblique muscle. What the superior oblique muscle does is it causes intorsion of eye. Now, what is intorsion? You see, the eye has different kinds of movements. Eyeball has different kinds of movements to it. So, if the eyeball, it moves towards the midline, it's known as adduction. If the eye moves towards away from the midline, it's called abduction. If it moves above, it's called supraduction. Below, infraduction. Okay. However, if there is a rotation, it's kind of a, um, if the eyeball, or the, you might say, yeah, the eyeball, if there is kind of an internal rotation of that, that might seem a little unrealistic, but trust me, that actually happens. Okay, so actually these movements, let me tell you, these movements are compound movements. These movements that all I'm talking about, they're compound movements. So there is a movement of the eyeball where it rotates inwards. I know it's sounding, I'm not very clear here, I know that. That's why you might have to refer to eyeball movements to know what intorsion means. But I'm actually trying my level best here to explain in whatever limited scope we have. Intorsion means that the eyeball rotates in towards the midline. Rotates, there is a small slight rotation of the eye. That occurs mostly when there is a supraduction. Okay, so that's why I was telling that it's a form of a compound movement. Like you cannot rotate your eyes just like that, right? But there is slight rotation inwards or outwards when there is some other forms of movement. Suppose supraduction or infraduction or adduction, abduction. They, associate with themselves some form of intorsion, which is inward rotation, or extorsion, which is external rotation. Okay. Now, why I am talking about eye suddenly? We were talking about the neck. Suddenly, why the eye is being talked about here? So, this is where, very interestingly enough, the trochlear nerve supplies a muscle which is known as the superior oblique. And superior oblique muscle causes intorsion. Now, if that muscle is, or rather, if that nerve, trochlear nerve, is damaged, then superior oblique will no longer work. It will no longer work. So there will not be any intorsion of eye. And the eyes will automatically, if there is no intorsion, there is zero intorsion, the eyes will automatically be in an extorted position. The eyes will automatically be in an extorted position, right? Because there is no zero intorsion. There's no muscle to intort the eye, so automatically the eyes will be extorted to that direction, right? So the person, that person who is suffering from this condition, what he or she will try to do is, whenever he or she will try to look at someone, he or she will turn his or her head or neck, or rather head, head, to the opposite side. Suppose we are talking about the left eye over here. So the eye is automatically extorted to this direction because of an incorrect or faulty superior oblique muscle. The person will automatically try to bend his or her head to look at the an object or any person, right? So that will cause a manual intorsion. That will cause a manual intorsion, which will cancel out the extorsion, and hence this will also lead to a bending, right? This will also lead to some form of bending of the neck, and that's why this is known as a trochlear torticollis or wry neck. Okay, so that's that about the torticollis or wry neck. So another cause for torticollis or wry neck might be congenital, and that's permanent, mostly permanent. That is from birth. If within the uterus or if within the womb there is some form of injury to the baby's head or neck, then the baby might be delivered with torticollis or wry neck, which is congenital and which mostly remains permanent. Okay, so that finishes off sternocleidomastoid as a whole. We talked about everything related to sternocleidomastoid, which is an extremely important key muscle. And the next time, I think it's been a long time for this discussion. I thought we would start posterior triangle, but we cannot. So in the next discussion, subsequent discussion, we'll definitely talk and complete the posterior triangle of the neck. And that discussion will be coming out very soon. So thank you. And I hope you found everything to your content here and got something out of the time that you invested in this. So thank you again, and hoping to see you again very soon. Thank you.